Hi, everybody. My name is Emelia Bachman. I'm from the Delaware Institute for Reproductive Medicine. Some of you may know me. Some of you we may be meeting for the first time on this. So hello, it's really nice to have you all here today. Happy Thursday. We are part of the Boston IVF Network. We're here in Newark, Delaware, and we have offices in Milford, Delaware, as well as our new office in Chaddsford, Pennsylvania. So hope you come to visit us there. We're really excited about that. So this is just an easy, fun Q&A where you can feel comfortable to ask your questions and I'll answer them for you. Just to introduce myself again, I'm one of the physicians here at the practice. I work with Dr. Jeffrey Russell and Dr. George Kovalevsky, and we have a wonderful team here in our office here to help all of our patients. And so some of you we may have already seen, some of you might be new to us, so we welcome you. We're really happy to help you. We know this can be a really stressful process, and so we're here to support all of you. I had some questions from before this started, so we'll start those, and I see there's some already in the Q&A as well, so we'll get to those. So one patient first asked about the resources available to patients at DIRM. So we typically, when you schedule a first patient appointment, we'll send you some informational videos as well. You'll meet with one of the physicians. We do spend a good amount of time with you to get to know you, to answer your questions. And then we have some information sheets on what the testing is. We'll explain that to you, and also either one of us or one of our amazing staff members will help you, schedule all of the testing. So typically, if you're new to this and you haven't had any testing before, we would test things like the egg reserve, your uterus, fallopian tubes. If you have a male partner, the sperm. Otherwise, other patients, if you're in a same-sex relationship or you're single, we have resources for donor sperm. We also have a nutritionist who is part of our team, and she sees patients via telemed for nutrition consults, and we do have other resources as well in the area. There are counselors in the area that we can refer to. There are acupuncturists in the area that we can refer to, and so many of our patients do take advantage of those amazing resources that we have, and we try to find someone who's closer to you. So we definitely have people who are in Southern Delaware, here around Newark, and also in Pennsylvania. Once we figure out what your treatment plan is, and I say this to all my patients, and I mean it, we want to go over all of your results. We want you to understand what you had done and make a plan together. It's important for you to know that, we will always be honest with what we think you should do. But at the same time, we have to come up with a plan that you feel comfortable with as well. And that's really important. And we also want to know the goals of your family so we can help you in the best way possible. We also have resources like videos on IUI, IVF, genetic testing that you can watch, and also that supplements our conversation with you. So someone asked me, do chances increase the more embryo transfers you do? First was a chemical, second did not take. I am so sorry that happened. And so my heart goes out to you. I know that's really hard. I promise you there's still a lot of hope here. And I think you also asked what are good questions to ask the doctor after 2 failed transfers. So I think I'll actually start with your second question first and then go into the next one. So one thing to make sure, and I'm sure most physicians would do this, is that we make sure that your labs are updated. We have updated things like thyroid, make sure you don't have diabetes, all your preconception labs are up to date within the year. We have up-to-date hormonal testing, again, like your thyroid, your prolactin, diabetes screen. I like to check vitamin D. And we also make sure the uterus is normal. Do we have an updated uterine cavity evaluation? Is there something in the uterus that may have interfered with implantation? And there can be some other testing just on an individual basis, like should we evaluate you for endometriosis? Should we look for chronic endometritis? There's other testing we can do. So I really it's always good to sit down, have a consult. And I always say, okay, let's see, how did the lining look? How did the labs look? How was our timing of this? When did we start progesterone? And just make sure all of that is okay. And then think about things and say, okay, should we try the same protocol? Should we try a different protocol? And again, first things first, always making sure that testing is updated. Depending on your age and whether or not the embryo is tested, that is going to dictate the chance for the embryo transfer. So your chance for the embryo transfer to be successful is always based on age. If you had done what's called pre-implantation genetic testing, or PGT, and we know it is genetically normal. And remember that that testing is normal with a 98 to 99% accuracy. So it's not perfect, but it's the best we know. And so we do think there are some studies that show shortened time to pregnancy and reduced risk for miscarriage, although unfortunately it's still not 100%. So typically with those genetically normal embryos, we see a roughly 60% implantation, 1% identical twins. If they're not tested, then that would be kind of age-based, right? So you said, again, the first was a biochemical, the second one did not take. So if you look at cumulative live birth rate, let's say these are normal, and I don't know if they are, but if you look at cumulative live birth rate, by the time you've tried 3, over 90% of people will be successful if it's a good prognosis and it is a healthy embryo. Again, I'm sorry, it could be more individual based based on age. So I don't know that information now. So definitely either, talk to your doctor about that to get that data on the success rates. So certainly I think after 2, I have a lot of patients who was the third one that worked. But we always, before we proceed, just try to say, okay, what testing should be updated? Anything we want to add? Let's look at the protocol and then proceed. Okay, but there are a lot of people in the same situation, but I know it really hurts, and I'm sorry, but I do know there is a lot of hope here. It is also important to know, and I think, the genetic testing is a screening test. We think that this genetic test, this is a karyotypically normal, either female or male, with 98 to 99% accuracy. But there could also be other things with the embryo that we can't test for as well. So that's something to remember. I think sometimes patients always think like, oh, it's me. And that may not be the case. But of course, we do want to make sure all of your testing is up to date, that we're not missing anything, and that we have the next best embryo to transfer. So I hope that that helps with that question. So the next question here, for the IUI cycle, what are the pros and cons for natural versus using medication? Can I do it consecutively over a few months? Which days of the cycle estimated to visit hospital can I still travel? Awesome question. I also have another question from before the session that someone said, how many times would you generally advise doing IUIs before moving to IVF? So I'll kind of combine all of that in one answer. So with the IUIs, the decision to make, to decide between natural versus medicated, I think it all just depends on your diagnosis, right? So if you are someone who has an ovulatory disorder like PCOS or hypothalamic amenorrhea or something, we definitely want to use a medication to help you ovulate, right? If you are someone who is either, single without any issues of fertility beforehand, or in a same-sex relationship with all testing normal, we could potentially use the medicated cycle. And some studies have shown for younger patients under 38 that adding a medication may only, increase the risk of twins, and doesn't necessarily help above that. But it is a case-by-case basis where we want to say, like, what is right for you, right? For some patients, if a couple of natural cycles have not worked, a lot of times I do add a medication, and there are some studies that show that could be helpful as well. Okay. If you're someone who's in an unexplained diagnosis, you have, a male partner, and you have been trying, the testing is normal, we do recommend both the medication and the IUI together, because in that situation, there isn't an ovulatory dysfunction. We have, normal egg reserve, open tubes, normal uterus, normal sperm. And while I know that can be a really frustrating diagnosis, that doesn't mean there isn't something else going on. There could be some issue with fertilization or implantation, or the sperm getting to where it needs to be, or maybe there is maybe some mild ovulatory dysfunction or something that's going on that we really can't test for. Maybe there's endometriosis. And that's where sometimes we start with a medicated IUI and try that for a few months to help egg and sperm get together. Okay. You can do them consecutively. So basically with the IUI cycle, if you have insurance, we make sure your insurance might not need an authorization. Sometimes that's like a key thing to make sure that you get the cycle paid for. You call with your period, and you typically come in for a baseline ultrasound. And that's to make sure that there's no cysts left over from the cycle before, that you're, sometimes you have a period, but you could have a positive pregnancy test, and you never know. Some people say like, well, I know I'm not pregnant, or I already had all these ultrasounds. But the reality is we don't want to give you an extra medication without knowing what's happening. And even with a natural cycle, we want to make sure we're not confusing maybe like a simple cyst at baseline with what's the real follicle. So that's the importance of doing the baseline ultrasound in the beginning. And then if you're doing a natural cycle, we may have you come in maybe on cycle day 9, 10, or 11. If you're doing a medicated cycle, we'll start the medication, whether that's a pill or an injectable. Again, depending on your situation, that would be something you come up with your doctor, that your doctor will come up with that plan for you. Everyone is different. I can't tell you exactly how many days you're going to come in. Most people come in somewhere between 2 to 4 times in the mid-cycle to figure out when is the optimal time to do the IUI, and then they come in for the IUI as well. The IUI is not painful. It is a small speculum, as long as you can tolerate that. We do have some patients who still have difficulty with that, and sometimes I give them a little bit of Valium or some medication or help them out with that to make it easier. But for most people, it's more like a pap smear. The catheter is super thin and delicate, guys. It's kind of like an angel hair pasta thin, and you just gently place it through the cervix. It is not painful like the tube test, I promise. So typically it takes about an hour, hour and a half to process the sperm, and then we can do the IUI. You can go back to work after that too. As far as traveling, it all depends on where you are in the cycle. If you're kind of that mid time where we have to monitor you and we have to know when to do the IUI, you may not be able to travel that time because we might miss the IUI time. But sometimes like really early in the cycle, maybe between your baseline and that first check and you're away for a few days, that's probably fine. Or when you're in that waiting period after the IUI, it's okay to travel. Okay, I hope that's helpful. Now, how many times do we do IUI? Again, this is different for every patient. If IUI is an option for you, and remember, IUI is only an option if you have open tubes, the sperm is normal. And so for someone who like has blocked tubes or really low sperm, it's not, the answer is IVF. But for, let's say, someone who is either in the unexplained or they have an ovulatory dysfunction, or maybe only one tube is blocked and you really want to try the IUI first. We usually say try about 3 cycles. And the reason for this is when you look at data, most people who are going to get pregnant with IUI typically get pregnant in those first 3 cycles. Every so often I've had the patient who told me they really don't want to do IVF, Dr. Bachman, please. And we try that 4th and we're happy. And for either, patients who are single or same sex where they don't have fertility issues prior, you may, maybe 3 or 4, may be reasonable as well. But at the same time, you have to think about what are the goals of your family, how, is there a maximum on your insurance? Also, sometimes some insurance companies often, unfortunately, make us try a certain number of IUIs if there aren't any other diagnoses. So it is variable. I usually individualize the plan for the patient. Some of my patients, after 1 cycle, they look at me and they say, you know what, I just want to do the treatment that's going to give me the highest chance for success. Or maybe they want a really large family and they're already starting at, after 35. Maybe IVF is the better option versus someone who says, I just want to try something that's less invasive than that. And I want to go through that process first, or maybe just medically, it's the right indication to just start with the IUIs. Okay. Other reasons some couples have difficulty having intercourse, and IUIs can be helpful and take some of that pressure off. Sometimes if the sperm is mildly abnormal, an IUI might be a good first step too. But again, typically just depending on the patient and we decide, but we usually say roughly 3, but it can be less than or more than that depending on your individual situation. And that's what I really want to stress here. This is all about individualized care, right, for you. I am 29 and my AMH is 0.88. How soon should I be trying to get pregnant? Also, when will that number be concerning? Okay, so this is a great question. What's important to know is AMH is one marker of egg reserve. It's called anti-Mullerian hormone. We have two other tests of ovarian reserve. One is called the day 3 FSH and estradiol. So you have to get them both together, and they can be done on cycle day 2, 3, or 4, as well as an antral follicle count, where we kind of count the follicles at the beginning of the cycle on an ultrasound. Again, these numbers will vary. An AMH will vary if you get it on different days. FSH will vary month to month. Your follicle count will vary month to month. But these ovarian reserve parameters, they don't predict live birth. Your age is the primary predictor for live birth. So I would rather you be 29 with an AMH of 0.88 than be 45, 46 with an AMH of 8. That having been said, it's still good to have a higher number. But this is where it is important to counsel patients, right? So the younger you try to get pregnant, the better your chances will be, right? That having been said, you may not be ready yet. So that's something where you may, if you're not ready to get pregnant soon, do you want to think about freezing some eggs? Or if you have a partner, you'd rather use donor sperm, freezing some embryos. Again, this is a conversation you want to have with your doctor to talk about your goals for life. But I do think if it's possible, sooner the better, or try to think about some sort of fertility preservation options. I would say there isn't like a cutoff where that number is concerning. Certainly at 29, that is below average for 29. But that, again, it does not predict whether or not you're going to get pregnant. It predicts response to treatment. So we see that studies show like kind of it predicts maybe a general like how many eggs you might get in an IVF cycle. There are many people who are likely getting pregnant with very low numbers and they have no idea, right? But certainly if you're not ready to get pregnant, I think you want to have a consultation with the board certified reproductive endocrinologist to talk about your options and then also maybe have that monitored. Another thing to think about with that is that everyone's different. We can't predict time to menopause since, just by one number. So some people just kind of live at that number for a long time. Sometimes it does decline. So certainly I think it's good to just get a consult, talk about where you are at that point in life, talk about what your goals are, and then we can help you. Okay. My next question is, I have a breast issue that can be a fibroadenoma or possibly an intramammary lymph node. Should I do a procedure to take it out before getting pregnant or IUI or IVF? I always think it's better to make sure that there is hopefully that is not, cancerous. Those are benign conditions that you just said. I think it'd be better to just make sure that that's okay before getting pregnant or doing any treatment. And I hope not. I hope it's okay. But if it isn't, we can do things like IVF to save eggs or embryos before some sort of treatment if someone does have a breast cancer. But again, those two conditions that you said are likely benign, but you probably want to make sure that that's the definitive diagnosis and that you're okay. And I hope everything will be hoping and praying that everything's okay. So the IVF videos talk about how egg quality significantly decreases after age 42 and is usually best before 35. But what about between ages 35 to 42? Also, does success on previous egg retrievals impact a personal embryo success journey? That's an amazing question. As we get older, our eggs become not only less in number, but they become more and more genetically abnormal. And that's just not our fault. And everyone is different, right? But we do have good success in IVF between the ages of 35 to 42. Again, it is better to pursue this as young as possible if you are able to. But there are percentages of abnormal embryos that we have based on age. And this is something that we can talk about with you. Typically in the mid-30s, you have about 50% abnormal embryos. 38 to 40, you have roughly 70% abnormal embryos, and 40 and above, you have roughly 80 to 90% abnormal. Again, these are really rough numbers. You're not a statistic, but it's just good to give you some sort of baseline just to understand a little bit. But again, sometimes, yes, it is always a good thing that if you've previously been successful, but again, the eggs can decline, in number and quality with age. So sometimes as we get older, more than one cycle may be needed. And then again, it just depends on the goals of your family. Next patient, I'm interested in surrogacy. I was wondering what the process is. Do you have any collaborative surrogacy agency? Should I reach out to the agents first? So I think it's always good to have a consult with one of us first to talk about the options for you. We have many agencies that our patients work with. Sometimes our patients find other agencies that they like, and we work with them as well. It isn't, you could go either way, but sometimes it's good for it just to talk about like what is the, what are the medical steps. So the first thing would be if you would be going through the IVF cycle. So we talk about you going through IVF, your testing, and creating those embryos to then put in the what we call gestational carrier. At that point, sometimes you can either use an anonymous gestational carrier, or you can use a known gestational carrier. Sometimes people have a friend or a family member or someone, a friend of a friend who is willing to be a carrier for them. Certainly the compensation can vary widely. So it is important for you to talk to us. We want to get your medical information, see, are you a candidate to go through the IVF process? And then with the carrier, once you identify a carrier, and again, you could do that through an agency or sometimes it's a friend. We want to look at their medical records, make sure that before you even proceed, that they are a good carrier. We see what are their prior pregnancies, are they healthy, non-smoker, the right age, a healthy BMI. They have not had severe complications in prior pregnancies. We like to review those records. Then what we want to do is do a medical evaluation. Also, prior to that, we would do a psychological evaluation. We do have all of our couples doing what's called third-party reproduction, talk to a counselor who's a specialist in third-party reproduction to make sure that the carrier is prepared, understands like the ethics behind this, and we know that they're a stable person to do this, as well as are you and your family, and you and either if you're by yourself or your wife or husband, if you are ready to do this as well. Then you also have to have a legal agreement as well. And as I said, we would also evaluate that carrier medically to make sure, the uterus is normal, the preconception labs are normal, and we make sure that like everyone is really on the same page with that. So it is good to have a conversation with us we go through all of that in detail. We do have agencies we work with. We can give you a list that we work with and go from there. Okay. Are you able to test the embryos for sickle cell disease in case both partners carry a trait? Yes, we can. So that is called preimplantation genetic testing for a monosomic disorder, PGT-M. And so what happens is that you would need to go through the IVF process to make embryos. We have to then get either cheek swabs or blood samples from you and your partner so we know what that mutation is, and that is sent to a genetic company that we work with, and they will make what's called a genetic probe to test for your specific mutation so that we can test the embryo. Often we do also recommend that we test to make sure the embryo is a healthy boy or girl. Again, I don't care about the gender. I just want you to have a healthy baby, but inherently you will see, is this a 46XX or a 46XY? And then does it have the sickle cell trait? Does it have sickle cell disease, or just not a carrier at all? Obviously, we know that either the carriers or the completely unaffected would be healthy. The ones that have both copies would have the disease. So you can actually test the embryos to know which ones are affected or unaffected with that condition. Again, you need to go through IVF first, and then we need to make that specific test for you. So typically that can take somewhere between 8 to 12 weeks. So the earlier you start the process, the better for that. But that is actually an amazing thing that we can do to help a lot of families with various genetic disorders, where if we find partners who both carry the same genetic disorder, or I see some patients who already know they have something and they don't want to pass it to their child. And it really is an incredible part of our science to help people have healthy babies who are not suffering with these diseases. So you have a consult with us. Again, we do some testing. We talk about the IVF process, and then we can get that genetic test prepared to test the embryo. These are amazing questions, everyone. And I also wish I could actually see you, which would be more fun. But I wanted to answer, so what are the most common causes for recurrent miscarriages at 6 to 7 weeks with unexplained infertility? Again, I am so sorry for that you're going through that. My heart goes out to you. I know this is really hard. I do recommend that you first have a recurrent pregnancy loss workup. You may have had that already, but for the purposes of answering the question, we want to check, the anatomy. We want to check the uterine cavity. Are there polyps, fibroids, a septum, retained tissue from another miscarriage? We want to make sure that the cavity is a normal place for implantation. Then we also want to check genetics of both partners. So sometimes something called a balanced translocation, which is actually quite rare, and we find it in a small percentage of patients. But if you've had multiple losses, we do recommend that both partners have chromosomal testing to make sure that their karyotypes do not have what's called a balanced translocation, which can be a piece of one chromosome and a piece of another switching spots. And then that could cause more and more abnormal embryos. Again, we probably find that in less than 5% of couples, but not 0. So that's important to get done. We also want to check things like immunological. So the antiphospholipid syndrome panel, and some other tests to make sure that there isn't an immunological component. If someone is positive for what we call the APLS syndrome, and you actually have to get 2 tests 3 months apart to actually confirm this diagnosis, we recommend aspirin and Lovenox. We also look for some, endocrine factors, your thyroid, prolactin, diabetes screen. I do like to check vitamin D levels. I don't think that's a direct, because there's some studies that showed an association with very low vitamin D levels in recurrent pregnancy loss. Again, remember, association isn't always causation. I think that it's tricky to remember that, but I always think it's something that it's good to just fix every little thing we can to give you the best chance possible. And certainly there's some other tests that are in more of a gray area that we can talk to you about and offer you. Do we check for chronic endometritis? Do we check for any other infection? And there's some other things that we can do to help you. I know that it really hurts to go through this, but I would definitely have a consult with someone if you haven't already. And if you already have with your doctor and you've had all this testing, then talk about, okay, like, where can we go from here? Because the reality is, for most patients, even if you've had 3 or 4 losses, there still is a really good chance of having a healthy baby. And I know that it doesn't feel like that, but I promise you, from where we sit, we know that there is a lot of hope. We just have to help you. Okay. So next one, 13 months of trying. 5 of those medicated and 1 with IUI is the right time to start IVF, or is that too aggressive, age 34? And I would be honest, I would say at this point, you've tried a lot of medicated cycles. I know you tried 1 IUI. You could decide if IVF you feel like is really not for you right away, you could argue to try 1 or 2 more IUIs. But if I were you, to be truthful, I would do IVF. And the reason is, in this situation, not only do you get the best treatment, but you get some more information as well. So for instance, if you're thinking about all those months, maybe ovulating 1 or 2 eggs, where an IVF potentially, and again, I don't know your baseline egg reserve, but let's say it's good. Potentially, if we got 12 eggs out of a cycle, that's like giving you 12 months of trying in 1 month. And we can actually see the eggs and see the sperm and see the % that fertilize, and see how those embryos develop. And then potentially, if you wanted to genetically test them, although you do not have to at 34, these are, again, options that you need to discuss with your doctor. And so we decide what's right for you, right? But this would give you a much higher chance. So IVF at age 34, a good looking embryo would give you a 50% chance for pregnancy, whereas those IUI cycles are roughly 10% a month. Okay, I do have patients who are positive with IUIs and they are lucky and successful. So I think you have to decide that timeline that's right for you and your family. But I do agree that something like IVF at this point would probably be your best choice. Now, it's not always the right thing for everyone, but it is going to give you the highest chance for success at this point. Okay. I plan to do IVF. How long to wait between retrieval and implantation? How long to wait between each implantation? Which days of the cycle should I visit the hospital? Which days do I need to rest? Very good question. So with IVF, it all depends on how you're responding. So if you are someone who has a really high egg reserve and you're going to respond really well as far as like having estrogen levels pretty high, a lot of eggs, we do recommend that you do a frozen embryo transfer to decrease the risk of ovarian hyperstimulation syndrome. Also, if you are planning to get genetic testing, you have to wait anyway for those results that usually come back about 2 weeks after we send the biopsies off. So it is a nice time where you have that 2-week period of IVF where you're doing the injections, stimulating the ovaries, we get the eggs out with the egg retrieval, and then you get a little bit of a break too. Just let your hormones, let everything go back to normal. And then that'll also reduce your risk for the hyperstimulation syndrome, which can happen when we have a little too high estrogen levels, a lot of eggs, and we can get fluid in the belly, fluid in the lungs. Do not worry. This is really, it's pretty rare, less than 5%. And most of us, a lot of my colleagues that I know, definitely all of us here in our office, we are really vigilant about watching you for that, picking the right dose of medication, dropping the dose as needed, there's certain medications to prevent that. And then the freeze-all cycle really does prevent that. Now, if there's someone who maybe you don't have a really high egg reserve and you're not getting that many eggs and your estrogen levels aren't super high, and maybe you've decided genetic testing isn't for you, you could potentially have the first best embryo put in 5 days after the transfer. Not many people are doing a lot of fresh transfers because most people are doing genetic testing or we're worried about the hyperstimulation. So we just want to let you get back to normal. It isn't so natural to get pregnant with an estrogen of 4,000 and your ovaries being really large, right? So not the best and not the safest. So we want to make sure that your body's okay. So typically, as long as you're, so then you have about a couple weeks where you're just resting, you'll get your results back, and then we can do the transfer in the next month, as long as everything's okay. As far as, let's say that one didn't work. Typically what I always do with my patients, and again, before I do any transfer, I'm always looking at, is all the testing updated? Are all the labs updated? Is everything where we want it to be? But if that one is not successful, which we know that it's not, unfortunately, it's not 100%, even with a tested embryo, it's roughly 60%, you can just try the next month. But I do like to take a step and say, okay, let's still make sure everything's okay. Do we want to do the same protocol? Do we want a different protocol? Make sure we have the plan. But there is nothing wrong with doing successive transfers. Sometimes mentally, if you need a break, that's totally understandable. So again, just talk with your doctor about that plan. As far as resting, I usually tell people the day of the egg retrieval, you've had anesthesia, you feel crampy, bloated, you definitely want to rest that day. And I usually say rest the next day, but most people afterwards, you can walk, you can use stairs, you can eat what you want. And usually when your ovaries are big, we just say no exercise or penetrative intercourse for about 2 weeks after to make sure those ovaries go back to normal. Okay. And we want to make sure we're preventing something called ovarian torsion where the ovary can twist on itself. Okay. As far as the transfer, your ovaries aren't big during the transfer process if you're doing a frozen transfer, because either you're doing a program cycle or a natural cycle. And so typically we just say, just some modified rest the day of the transfer. We really have shown that you don't have to lay there in bed all day. That is not helpful. I always, my patients will laugh. I say the same thing. It's not time to run a marathon. It's not time to climb, mountains. It's not time to move the furniture, but you just be normal, right? You don't have to lay there feeling like, oh my gosh, I coughed or sneezed and now the embryo won't implant. You can go to the restroom right after the embryo transfer. It's a different organ. And we all feel like this in our head. It's hard to change your thinking sometimes, but it is okay in there. So we usually say just kind of be a normal person, and we tell you just to avoid really strenuous things. Okay. I hope that's helpful. What is your suggestion? Oh, in your opinion, how effective is acupuncture? Would you recommend it prior to hormone therapy or IVF? I think acupuncture can be great for a lot of people. There are some small studies that looked at improved blood flow to ovaries and uterus, some small studies that showed improved success. There was a meta-analysis, though, that showed no difference in live birth rates. Again, no study is perfect, but we're not. So I think everyone doesn't have to do that. That's my take-home message is you don't have to do that. But if you feel like this is something that would help me, it would help me mentally, would help me relax a bit, Maybe for patients who have a lower egg reserve, who are just trying everything they can, I definitely tell patients, if you want to do it and it makes you feel better, then please go ahead. If you're doing it and you're just either stressed out by the process of it, the money, the time, then I don't think it's helpful. Okay. What is your suggestion on how much folate to take per day? How much CoQ10? Okay, so folate we definitely recommend for everybody. Okay, so you need this for your prenatal vitamin. This is to prevent things like spina bifida and anencephaly. These are called neural tube defects, when the neural tube doesn't close. And that's happening really early in embryo development. So we really like you to be on a prenatal vitamin even a couple months before you start trying. But that doesn't mean you have to wait to start trying it. We just want you to start it. Definitely be on your prenatal vitamin. We want at least 800 micrograms of folic acid. Now, if you're someone who's had a child who's had a neural tube defect, or you're on some certain seizure medications, you may be recommended to take 4 milligrams. So that's something that you need to talk with either your reproductive endocrinologist, your OBGYN, the maternal fetal medicine doctors. But for everyone overall, we say at least 800 micrograms of folic acid or folate per day. And then there might be more than that if you have a risk factor, like a certain seizure medication, or you've had a child who's had a prior neural tube defect. Also, another component of the prenatal vitamin is something called DHA, or the omega-3 fatty acids. These are good for brain and eye development, so make sure you have that in there too, okay? And you can find something. Some people don't tolerate all of them. There's all different ones, all different sizes, gummies. You can find something that works for you. How much CoQ10? So CoQ10 is an antioxidant. There's some small studies that show, does this potentially improve egg quality? Or it's an antioxidant, right? So it could be helpful. I think there's not a definitive answer on this, but we do think in general it's safe, it's low risk, it's very reasonable to take. And so the study shows 600 milligrams a day if you want to do that. Okay. I also want to go through, there was a couple more questions from before. Someone said, what is the average amount of embryos collected during a retrieval, and how many eggs are needed for a successful pregnancy with IVF? Okay, so these two questions, it's really important to remember that this is age dependent and also dependent on your personal ovarian egg reserve, right? Some people are going to get 10, 20, 30 eggs. Some people are going to be really lucky to get 5 or 6 or even a couple. And so that just depends on what your baseline egg reserve is. Of course, what I like to look at when I counsel my patients is we get these egg reserve parameters. Remember earlier, we talked about age is your primary predictor, but these egg reserve parameters can tell me how you may respond. So that can help you say, hey, I think you should get somewhere between 10 to 15 eggs. I think, we should potentially from that number of eggs get this number of embryos. It is important to know everyone is different. So it may depend on the sperm quality, it may depend on egg quality, it may depend on your underlying diagnosis. But there typically is attrition in the process. So maybe we get 10 eggs, perhaps 8 are mature, maybe 5 fertilize, and then maybe we only get 2 or 3 embryos at the end, versus someone might get 30 eggs, right? And then they may be actually still left with maybe 5 to 10 embryos. And I will tell you, I've seen every version of this. I've seen people with 5 eggs get 5 embryos, and I've seen people with 30 plus eggs only get 1 or 2 embryos. And there could be like, an egg or sperm quality issue. So unfortunately, there isn't one answer to this. It all depends on what is your age, what is your partner's age, how are the eggs, how is the sperm, what are the ovarian reserve parameters? And then we can talk to you directly and say, hey, this is what I think may happen. And then typically once we do a cycle, we can see what's happened. And I usually review that with my patients, typically when we're reviewing their plan for their frozen embryo transfer, or if we have to do another cycle. Sadly, I always remind patients that every month we have a different group of eggs. So that's another variable. Every month there's a different cohort, and you may respond differently. And often I do like to tweak the protocol. You don't want to do the same thing again, but I have done for some patients who really liked the protocol they were on, or really helped them, or they already had those medications. I've seen very different results, even doing the same protocol, in different numbers of eggs and different numbers of healthy embryos. So each month is different. And then again, these answers are going to depend on your age and your baseline egg reserve parameters too. And that's how we can try to help you predict. Okay. Great question. Can you talk a little bit about how you treat patients with endometriosis and if it affects their chances of getting pregnant? So endometriosis is a condition where it can cause very painful periods, pelvic pain, pain with intercourse, pain with urination or bowel movements. And so sometimes if you tell us, this is a lot of times when we're talking, I ask you these questions. Hey, do you have painful periods? Do you have pain in between the cycles? Do you have pain every day? And so we can get a clue that clinically you may potentially have this. Now, the way to definitively diagnose this is called a laparoscopy. So we put a camera inside, we put it inside the belly button. You can go to sleep, of course, because that would be very painful. And that's the gold standard to see, do you have these endometriosis lesions? What are they? They are cells. They're kind of like the glandular cells of the endometrium that are implanted in our pelvis. And they can be anywhere in the pelvis, on our ovary, tubes, the bowel, the bladder. There's some rare conditions of it in the lungs. And so it can affect, so we know that endometriosis can affect your chances of getting pregnant. It can affect either the ovaries, the tubes, the implantation. We have many patients who have endometriosis who sometimes get pregnant on their own or who get pregnant with IUI or IVF and or surgery. Okay, so first, I talk to you about, what are your symptoms? Are you in a lot of pain? Have you had this diagnosis before? Has this been confirmed? And then we decide, we still doing the initial testing is always important. And then we decide, is a laparoscopy correct for you? Is moving on to something like IUI or IVF? And so we just make that right decision for you. So there isn't one way to treat this. And we have different ways of approaching this, and it all depends on your symptoms and your testing results. And then also, your wishes too. It's your life, right? So we decide what you feel comfortable doing. I'm currently on Clomid, waiting to begin IUI. I finished Clomid 15 days ago and have not yet ovulated, currently on day 22. Can Clomid cause ovulation issues? I've typically ovulated in the past, just have been unsuccessful getting pregnant in the last year. It's also important to note this is my first cycle post-miscarriage. Again, I'm so sorry for your loss. Clomid is supposed to help us ovulate, right? That having been said, every month can be different for us, right? So it may be that this month your body hasn't responded to that yet. So when it could just be the cycle where we may need to potentially increase the dose of the Clomid or try a different medication, or sometimes it depends on the results. What I see, like it would help to see what is the estrogen, the LH, the progesterone, what does the lining look like? So when I get all that information, I can decide, hey, do we want to almost like start over again in another cycle? Do we want to increase the dose of medication? Do we want to change the medication? It should not cause you to not ovulate. It is an ovulatory drug. It just might be that right now your body might not have responded to it so quickly. And everyone responds very differently. And when we're taking a medication, it can be different than our natural cycle. Also, sometimes after the first miscarriage, it can take a little time to get that first period. So I would say, I'm assuming you're getting monitored. What I would do is potentially maybe check it again, and then maybe see, like, do we want to go up on the dose? Do we want to change things around a little bit and then go from there? But I don't think that is causing the ovulatory issue. It just might be this cycle might be a little dysfunctional, and then we can do something to try to fix that. Okay. Recently miscarried my first. I have PCOS, but no insulin issues, and embryo was not abnormal. I am so sorry. Reasons for this happening and how can I feel comfortable this will not happen again? One, again, I am so sorry. Remember that even if it's genetically normal, there may have been something else that we can't test for. I think it would be good to just make sure your testing is updated, all your PCOS labs, making sure, and like you said, your insulin is normal, but you're not pre-diabetic, everything's okay, your uterus is normal, and checking a lot of those labs that I had mentioned earlier in my talk today. And so I think no one can guarantee that it won't happen again. And I'm sorry to say that, but what we can do is check that blood work, check your uterus, make sure there's nothing there that we couldn't modify or fix first. And then we help you again. And again, depending on age, Again, success rates may be very, very good that you will get pregnant again. And I think you just need to, talk with your doctor and just make sure that, everything's getting checked before you start trying again. But there is a lot of hope and there is a good chance of having success. Okay. I recently moved to Delaware. What should we look for in picking a fertility clinic? Well, we would love to help you. I'd love to take care of you. But really what I think you should look at is, have a consult, make sure you're being listened to, that who is your contact in that office, that that your plan moving forward. I think there are, obviously, we feel like we take really good care of people, and we really, we are very proud of, our pregnancy rates and how we take care of our patients. We really focus on really personalized care here. At the same time, there are a lot of wonderful places, and we are friends with everyone, a lot of people in the country. And so you just have to pick the right place for you. And I think that that's important. Also, sometimes it is important to see, is it, what's my work schedule like? Is it close to my house? Again, am I connecting with the people? Do I feel listened to? Do I feel heard? Do I feel like my questions are answered? Those types of things. Okay. So those are really important. After all labs and testing have done and everything is fine, the only problem with my partner is low motility due to mild varicocele. What are the chances to go for IUI to work with us comparing to IVF? Okay, so that's a really good question. Again, unfortunately, that is going to depend on your age, which I don't know. But, IVF is always going to be a higher chance for success. But if you are under 35 and it's really just mildly low motility, it is very reasonable for you to try IUI first for a couple of months, if that's really important to you, to try that first. Again, to give you an exact percentage, I would need to know your age, but typically in the younger ages, if that is the only problem, you may have more of like a 10 to 15% chance. If you are older, it may be only about a 5 to 10% chance. And again, it just depends on the age. And then also sometimes when we wash the sperm out, like we need to make sure that total motile count is still good. So if we get to the IUI and that total motile count is less than 5 million, that is going to be a low chance even with the IUI. And that's where I definitely recommend moving on to IVF, or if a few IUIs haven't worked, then move on to IVF. Okay. Another question I was asked, what are the odds of success from frozen eggs? And this patient, her eggs were frozen at 47 and you're now 44. So for, with egg freezing, we talk about probability. Unfortunately, no cycle of egg freezing is a guarantee, but we know it is non-experimental, and we know that, it can improve our chances, right, for success in the future. I would rather have 10 eggs from 37 than 10 eggs at 44, because the chance to get pregnant would be better. Again, you have to remember that unfortunately it's not 100%. So typically what we look at, we do have some, programs and some data that show us just some probabilities based on age, on how many eggs for, a certain probability of live birth. So typically, if you look at studies, one egg would probably give you about a 4 to 6% chance of having a baby, right? It's not, one egg does not equal one baby, sadly. And I think, again, it depends on how many eggs you froze at 37, but like if you froze roughly, 10 to 15 eggs, you would likely have about a 50 to 60% chance of that being successful. Again, you're not a statistic, but we do have some data that we can extrapolate from some patients prior who have come back to use their eggs. And there are definitely some some calculators online as well that you can use based on your age and your AMH, the age at which you froze them. Remember, the chance is going to be dependent on the age that you froze them. Now, are they all going to survive the thaw? Will they fertilize? What is the health of the sperm that you're going to use as well? But again, that initial success is based on the age that you froze them. So I don't know how many eggs that you froze, but I was saying, if you had 10 to 15 eggs, it'd be a roughly 50 to 60% chance of having a live birth. Okay. We are actually, I'm so sorry, we are running out of time right now. I could talk to you all day. If you have any more questions, we do have some more questions, but I apologize. I'm running out of time for today, but we can definitely get back to you. And then also, if you would like to make an appointment, I would love to see you, or Dr. Kowalewski, Dr. Russell, anyone here in the office. We're all here to help you and help you on this journey. We know it's stressful. We know you'd rather not have to see us at all, but we are here to help you, and we're honored to go through this with you and do, and make a plan that works for you and your family. Okay. Thank you all so much for joining me today, and I hope to see you again soon. Bye.